Let us start our work. Good afternoon, dear colleagues, dear ladies and gentlemen, dear friends. I'm happy to see you today. Well, I would like to have more of us, but we'll start our work because we have to start now. And Sergei Morozov, Chief Specialist in X-ray Diagnosis of Department of Healthcare of Moscow, we're going to congratulate our specialist, Doctor of Functional Diagnosis, with the award he got. This is Pavlov Vladimir Ivanovich, Doctor of Medical Sciences, Head of Department of Functional Diagnosis, Sport Medicine for Moscow Scientific Practical Center of Rehabilitation and Recovery in Sport Medicine. Leading scientific employee of functional diagnosis of sportsmen. He worked for 20 years, and in this institution he has been working for 16 years. Doctor of highest qualification category. During his work, he published multiple scientific works, more than 300 theses, more than 330 articles for different magazines, and including in foreign editions. He had six chapters in books and monographies. He provides high-qualified consultation services and specialized medical assistance in functional diagnosis. For the most part, oriented at sportsmen and physically active people, identification of reserve capabilities, hidden pathology, potentially dangerous while performing physical work. He performs functional examinations to members of national teams and also teenagers and children, dealing with sports and physical culture, seminars with the trainers, educational work, expert issues related complicated cases, explanation of instrumental researches which are based on providing conclusion on acceptance to sports. And he is an expert of Russian Association of Specialists in Functional Diagnostics, and he is also head of the session at Congress and leader of this trend. He is member of many magazine's editor. He is striving to implement lots of prospective functional diagnosis technologies, verification of pathological conditions and identification of conditions of sportsmen based on fundamental laws of sports. I would like to say a lot about Vladimir Ivanovich. I have missed half of that, and we congratulate you on that. You are honorable specialist. We are proud of you, and for 1 year you will have the title of Best Specialist on Functional Diagnosis. And this is the diploma. We congratulate you, Vladimir Ivanovich. Thank you very much. Thank you. Well, you know, first of all, Vladimir Ivanovich got strong support on the applaud, which sounds even before she enumerated his main titles. The second thing is when there was voting for the specialists, I introduced Vladimir Ivanovich for the commission of Moscow contest, and I was pleased to mention how much support was provided from the colleagues when I was said. And the documents supplied for the contest, these are the documents of the most deserving specialist, and I'm happy that he got this reward, and I wish all the best and further success, and I hope that methodological support of our center and the work of Victoria Pavlovna will also give results for the whole community. So be successful next year as well. Thank you very much. Thank you. Thanks to all for this support. I'll try to be worth of your trust and prove this further on to be useful to society, sports, and functional diagnosis. We'll continue. Thank you. And now, as we are quite pressed for time, I would like to start our work. And I would like to introduce Ivanov Sergei, Scientific Clinical Center of Russian Railways, Professor, Doctor of Medical Sciences, Head of Department of Functional Diagnosis of Scientific Clinical Center, Chair of Functional X-ray Diagnosis, Department of Continuous Medical Education, RUDEN. The first theme, modern approach to tests. So, dear colleagues, today's speech on modern approach on arrangement tests, load tests. If you read or look through some monographies on tests, then the task that you might have, you will find for many pages. And I should say that all the tasks are in 2 points: diagnosis and assessment of distortion of this or that function. We all got used to diagnosis of ischemia disease, and this is the only nosological unit which is diagnosed with a loading test. And as I'm going to continue at other distortions of blood circulation functions, the very diagnosis is done with other methods, and we only assess the degree of distortion of this or that part of blood circulation system. So in our assessment, we have a kind of small but still some details. What is this and how we assess this? We assess it in a non-invasive load test. So if we imagine this result, if we imagine that this is coronary blood circulation, and if we have some stenosis or occlusions in vessels, then coronary blood circulations cannot be increased up to the psychological limit. And of course there is a pathological limit to that. And to identify this pathological limit, we use some criteria. This is electrical cardiography, and we have this kind of test, stress echocardiography criteria. And in order to assess this, we need to get to this distortion. For that reason, test has to be multiple with a constantly increased load. And we also need to assess the degree of load in some units. To assess it quantitatively, we mostly use the unit of load capacity. And thus, what this load test consists of from the protocol, we call the methodology of dosage of load and scale of assessment out of diagnostic criteria, out of test constellation. Just mention that these are different categories and assessment and interpretation of the results. Well, what kind of protocols exist? There is one protocol which is almost unused in cardiology, and with a continuous load, and when there is load not for 3 minutes but for a minute or 30 seconds, and after 30 seconds, when we get the load, we get almost continuous load and growing load. This is for 3 minutes step, or sometimes a little bit more time, and step-by-step load with the rest for every step. The last is normally needed to get additional diagnostic criteria, as I'm going to show you further on. And as you know, the tools to create load, now this is the ergometer and the treadmill, and this is one of multi-step protocols, treadmill tests, and actually treadmill test protocols are multiple, more than 20, and this protocol is made to increase the load through one metabolic unit, and this is a protocol of increasing metrics, and well, as the degree of insufficiency of function distortion is assessed with the lowered scale, what kind of scale do we use? We got used to external load scales, and more optimal is that metabolical scale, which is based on oxygen consumption, and it can be used in milliliters for 1 kilogram of weight, but more often in metabolic units or in percent of oxygen consumption to maximal suitable for this patient. And double reconciliation is not used because we have now beta blocking agents. And what is typical of metabolic scale of oxygen consumption? You see the dependence between the external scale and oxygen consumption, and the final result of the whole cardiorespiratory system during the loads is delivery of oxygen to tissues, and in connection with this, oxygen consumptions reflects the load over a breathing system in comparison to external load. The used metabolic item is oxygen consumption. The unmoving person, if basic exchange is normal, then it is 3.5 or 4 milliliters for 1 kilogram of weight per minute. Here we have regulation not only for 1 kilogram of weight, but also for calm condition. And if at 5 metabolic agents, this is energy expensive related to calm condition in comparison to steady condition. It is also convenient to identify a final load for this patient as long as there is calculation and metabolic units for every population, which are characterized by age, gender, height, and that is why this can make like 50 or 40% from maximum load, and it's harder to understand the position itself. And 50 watts stimulate different oxygen consumption by different patients, and these are different functional classes. And we can actually speak about critical level to routine and professional activity, and thus arrange rehabilitation programs, and it will be easier as well. Well, we have a classification alongside with the metabolic units, which was invented with the ischemia, and now it's used for other methodological units. This is an example of translation of test results. Actually, every kind of physical activity, routine activity or professional activity is measured in metabolism unit. You can see 5 or 6 metabological units, and a patient who would have a diagnosis for treadmill test or ergometry of ischemia would have a functional class, and he will ask, can I work in the garden, and what kind of load I can make? And here you can understand there are some rules actually, and I'm not going to speculate about this. Well, now criteria. What kind of non-invasive diagnosis criteria can happen now? This criteria is very important. Why? Actually, myocardial ischemia is well known to you. This is electrical cardiogram, and it is identified like this: insufficient heart function. For that, we use, as I say, cardio load test, and we can also use stress cardiography, pathological arterial hypertension during the load, and every load test. Lungs hypertension, ischemia of lower parts, and the importance of diagnostic criteria is very important. It's very high, and fantastic example I can provide. If we had a criteria of non-invasive criteria of mitochondria function distortion, then in any load test we would easily assess mitochondria function. Just for instance, What kind of load tests, depending on criteria and on approaches, we have a routine test in choreography and cardiopulmonary test and stress cardiography test to assess arterial insufficiency of legs. And echocardiogram criteria, you know. This is depression of segments for 1 millimeters and more, horizontal, ascending, descending 1.5 and more. And there is a raise of segment during the load very rarely, and the origin is not clear still, as it's not enough, and we just make more energy consumption in comparison to its delivery to coronary thing, and this is related to closed vessels, and that is not often used, and it can be used in criteria only when we have no scar changes. And in this case, the raise of ST segment proves about dyskinesia, that is motion distortion. The ischemia criteria in literature, while analyzing 280 works within the last 30 years, it happens so that the specific feature is very distorted, and it's from 50 to 90%. It was a little bit higher for 3 depression of ST segments, and that is a very good prognostic value, below 72% for ascending depression of ST segment. And here I would like to show the correlation of cardiographic stresses and electrocardiographic stress. Here we see that distortion is done there. So this is ischemia. And if we are oriented at a depressed segment, millimeters or more, then we see the double difference. However, if we see the beginning of depression, this will be 5 metabolical units. And that is mistaken, 1.5 metabolical units. Using the criteria of a millimeter of depression, we actually make it much easier for the patient. So this is third functional class, and he got into the first one. And at the beginning of depression, that is the second. And in the group, we had it very well. The beginning of distortion is 3.5 metabolic units, and at the beginning it is 3.8, very close to that. And speaking about a moment of depression of 1 millimeter, then 5.3 metabolic units. So just to summarize, this should be with increasing load for 1 metabolical unit of 1.5, and if we want to assess the degree of load, diagnostic criteria should be for 1 millimeters and more.
But criteria for this ischemic disease must be depression of the segment. So you need to search and understand when the depression started. And now an efficient of the heart pump function deficiency. It leads to an improper volume of liquid of the blood. So that is why the necessary criteria is to when it appears. What is about the stabilization of the minute volume, or when does the growth of the volume stops? I mean, when the volume was normal. We can use this kind of cardiopulmonary load test for that matter. In fact, you know how it works. So you measure pulmonary ventilation and also CO2 considerations, also oxygen consumptions, the CO2 extractions to do that. This is a gas analytical block. The patient must be wearing a mask. It is used in cardiology with post heart attack cardiosclerosis, with congenital and also acquired disorders. What about the criteria of this heart function deficiency? This is exactly how it can be analyzed. What about anaerobic threshold? Anaerobic threshold, when you have physical activity and load up to 40%, oxygen goes to the muscle cell. We have mitochondrion. We use this phosphorus acid, 3.6 millimole per 1 molecule of glucose. But sooner or later it finishes and at 30 or 40% of load. So then we have a mixed load, and then it is basically anaerobic. The golden standard is the dynamic of the milk acid. Here, hardly anything changes. The concentration of this acid goes up and starts to progressively increase. Threshold is quite even. When we see decompensation of metabolic acetyl, then we have oxidization of blood, pH goes down, and you can use have special indicators. For example, CO2 extraction and dynamic of the pulmonary dynamics using special equivalents and concentration of CO2. It means that when lactic acid goes up in volume, then since this is acid, the number of efforts goes up, and in order to prevent acidization of the blood, some additional CO2 is produced. That is why this chemical CO2 creates this the buffer no longer works, and respiratory compensation is there to produce as much CO2 as possible in the atmosphere, and the CO2 concentration goes up. This is the lower graph. Based on this criteria, we need to can identify anaerobic threshold, etc. As for heart deficiency in general, this range of lower loads is a little bit shifted, and we have the threshold of 3.3, whilst healthy patients demonstrate the threshold of 7.8. I should say that the weakness of this criteria of this anaerobic threshold is explained by the fact that even healthy patient also sometimes can demonstrate, and if we receive it after 40%, we do not quite able to say whether it is heart deficiency or it is something else. They have very low sensitivity, but at the same time quite valuable from the diagnostic point of view. It is used for very severe, difficult patients who demonstrate this figure even at very low loads. While looking for additional criteria, we decided to use such a volume as oxygen debt. We can see that load goes up, oxygen consumption goes up, and when loads go down, then oxygen consumption goes down a little bit more steadily. And this is exactly what is called oxygen debt. So when again the loads load goes up, then we have a repetition of this scenario. Here are the formulas put at the bottom of the screen. If we have insufficient inflow of the volume and increase of the volume, it means that there is not enough oxygen in the muscles, and then at the moment of when stabilization happens of this minute volume, then oxygen debt happens. So it means here that we have recovery coefficient applied, and as for aorta insufficiency and pathology, we see that it's well demonstrated. But as for aorta and problems with mitral valves, we immediately see stabilized 1 minute volume, as well as stabilization of the oxygen depth. For such patients, we can use the same classification that was demonstrated for metabolic units. This balance between oxygen depth and aerobic threshold is as follows. First, we have some insufficiency of the function, then this process, and of course we switch to anaerobic modes, which is normal. But there are situations when we have pretty much the opposite situation. We call it pseudo anaerobic thresholds, and it shows that the patient gets out of breath not because of metabolic changes in the muscle, but because of some pulmonary reflections. And we also see here the so-called Kitaev's reflex and cardiopulmonary load test in cardiology. It is very important. It is an indication for cardiosurgical operations. By the way, this is the only test, selection methods in interdiction for heart transplantations for further survival prognosis. Once we have certain reserve, or if it's not enough, then an operation might be postponed. We also analyze the efficiency of conservative and surgical intervention in such scenario. Now we have ischemic distortions of the limbs. If there are such affection, then we will be work in a different way. We can use Dopplerography. It can be attached to the back of the knee. And after a load, we can see this distal flow, and the time of its existence is also very much linked to the lactic acid of blood. As for those with the occlusion of the iliac artery, they demonstrated an absolutely different picture compared to the opposite situation. The logic is the same, and the earlier this break of the curves happens, the bigger the aorta insufficiency of the limbs is. So this is before and after conservative treatment. We witness here over 4 different stages. These are group results of surgical treatment. So ischemic disease either disappears completely, or it only appears when the load is way higher. Particularities of the modern load test. Multi-stage test with a gradual increase in loads and further assessment. And just to be on the safe side, I decided to share some reference. And thank you very much for attention. Thank you very much, Sergei Valerievich. I think that we will leave our questions for the end of the session. And if you have any questions, please be ready, because then we will answer them. And I would like to give the floor to our next speaker, Ivanov Lev Borisovich, head of diagnostic departments and also department for consultations and the Children's Hospital named after Speransky, and candidate of medical science. He will be talking about psychophysiological interpretation of the brain state based on the encephalography. First of all, I would like to understand, do we have a lot of neurophysiologists here? Because depending on that, I will shape a little bit my presentation. Well, at least I can see some of you, which is really nice. Отлично. So some time ago, the appearance of encephalography appeared a new epoch in our work, and for quite a long period, within 8 decades, the main subject that was studied was epilepsy. And a lot was done in this direction. And I would like to thank our epileptologists because thanks to their efforts, the methods was ranked really highly and filled in a certain niche in medicine. At a certain stage, it seems that encephalography have nothing else to offer, and all the graphic elements specific for encephalography were already discussed. And as for the qualitative assessment of the remainder of the rhythmic and brain potential, well, it was outside doctors' interest, and it was difficult to study what encephalography consists. I mean, if you wanted to add something more on top of that, it was really unsuccessful. The time came, time of computer-based encephalography. It was a pivotal point when a lot was done in a completely new aspect. And it was the basis of electroencephalography that is based on 3 main components, which is, of course, optimization of mathematical processing approach of those signals, spectral. When I think optimization is not just how we estimate or calculate, but how we try to offer this information in the most affordable and understandable, transparent way. The second one is experimental approach and development of the relevant basis, neurophysiology. And with the appearance of computer, it became much easier to do that. And in red you can see the studies conducted in the sphere of neurophysiology. And those working there can hardly imagine how much has been done in the sphere of neurophysiology was done with the help of electroencephalography. This literature is quite rare, not so many clinicians read that. Initially, all these efforts to find a link between rhythmic and certain trends failed. So those, for example, with vascular dystony, they saw that it gave nothing for them. There was a polymorph picture of symptoms, and the same was seen on the encephalography. But when the same patient to the psychiatrist, they never look at your reflex, but they assess psychiatric symptoms and the way or character of thinking. When I started to analyze encephalography and try to compare it with the way of thinking, we saw that encephalography was retailored based on those complaints. It turned out that the major obstacles was lack of an understanding what the functional state of the brain is. In practice, it was substituted by some frequency descriptions. Some of them are higher, some that's more, and that was basically it. But that is not enough, because of course more and more doctors want to know what processes happen in the brain, rather than just frequency composition of encephalography. If we look at the guidelines for encephalography, you will see that it's absolutely easy. We have 2 functional states, which is sleeping state and state when you are awakened. But what about awakened? We do not analyze them and their state of sleepy state because they are completely different. Even physiologically, they are different, both from physiological point of view and pathological. And so those changes in the states can be not just local but also regional, and it can be particularly seen those models that can be seen by the doctors and their practice, especially with attention deficiency syndrome. But when we look at encephalography, it seems like we see a reduced time of the awakened parts of the brain, and also it is seen that it is regionally modified. Here is a mechanism just for understand how this level is managed. We have two letters, A activating and this prefrontal cortex shows that we have if we have no stimulus, no motivation, then it works in this way. Why little kids sleep so much? Because they have no experience. They have afferent signals coming only if they are hungry or if they have some skin irritation or some pain symptoms. Only in this case they wake up. But as for wake lights, they sleep for 20 hours if there is no female lying out around or if they are not hungry. That is why I say that this frontal cortex participate in this regulation. It activates different center, and all of this is also dependent on the braking system of the body. Can we look at data, the encephalography? Yes, of course. We can do it very easily. But let's go back to the thinking process, because I thought if psychiatrists decided to look at this, they will look at the way of thinking. To do that, we will go back to the psychology and look at the three levels of thinking activity. The first one is adaptational. This is an active process. Here we have afferent and also a response to the afferent response. Any thinking processes active one is related to these two systems. So if I say something interesting, then you have two first level. But if I start to say something boring, then the second one will be put into operations. And if we don't have afferent irritation, then we might think about very different other things, which is very similar to the dreaming, and we have a lower level of wakefulness.
This level of thinking. Well, very often a child is addressed, for instance, the syndrome of attention deficit. He looks to be active and he's running. You call him by name, but he cannot hear you because his brain is occupied with his own thoughts. The third level is the level which is connected to regulation of internal bodies, and none of healthy people identifies this level, and it's somatophore disorders and hypochondriac disorders. This level goes out to the first part, and a person starts touching his heart, his intestinal tract, and he finds different diseases in himself. And this level can be found when there is kind of information. For instance, like Ivan Ivanovich has a heart attack, and every person would feel that his heart is in another position, but it is lost very quickly. But with people who have abnormal thinking, this feeling of false perception of disease with the absence of true somatic diseases is dominating, and it prevents them from life. And now let's get back to decreased level, which prevails at the thinking level. And I already told you, in equal zone of activation and being slowed down. And now let's speak about the following thing. In order to assess encephalogramma from the position of psychophysiological analysis, we need to identify three components of functional condition. That is assessment of level, peculiarity of thinking process as to its expressiveness, of neurotic pattern of EEG, which can be checked by electroencephalogramma with the clever name, assessment of structural functional organization of thinking activity as to forming of criteria of hypofrontality and hyperfrontality. What do we mean? Berger, you know the name of Berger. He actually established electroencephalography, and he got disappointed in own idea to diagnose psychical disorders, because initially he was a psychiatrist, and actually the tool that he used didn't allow him to do that. And at current opportunity, at our current computer capabilities, we can assess functional connection inside the brain and a degree of participation of pre-core organization, forecasting the work of other brain departments. That is why there was such a phrase, structural functional organization. Hyperfrontality means a decrease of connection with the pre-core, and hyperfrontality can happen at anxious effects as one of the assessment criteria. Well, nothing new in assessment of level. I cannot tell you, because we are going to assess with well-known means, and considering encephalogramma of a person, we cannot assess whether there are components of sleep. And actually, the unsleeping person has lots of different indices of decrease of this level. This is change of frequency of space organization of alpha rhythm. While falling asleep at initial stage, it has a tendency for spreading and slowing down, and also on showing of the slow activity. It is present by everyone, but it's expressed locally, and its excessiveness helps to assess and name the decrease of this level of not being asleep. Here is an example. If you see electroencephalogram, you see synchronous waves, which do not reach the level of flash. However, this is remaining of sleep, and they are one of criteria which help to assess the level of activeness. And this kind of encephalogramma is it is not clear because this is laid low or slow or faster, non-pathologic, as while a person is in coma or something like this. But some accession of the activity is also a degree of activeness level, preserving alpha rhythm. Here is the same thing, some gene index synchronous waves, and this arranged in central parts. Then, quite often we see this issue with an active person and we never considered it as decrease of the level. This is sleep spindles. Sleep spindles proves that the level of activeness is distorted, and low voltage dysarrhythmia. And if somnologist would be shown that, he would say that this is initial sleep. This encephalogram can seen by the active people, clinical active people. Now let's get back to thinking activity. We can identify neurotic patterns of electroencephalogram, which were first oriented considering clinical picture, and we can see some mixed type and normal activity type. Those who know encephalogram can actually suspect that this is the different things. This is deepest anxious effect. In your forehead on a spectrum, there is a spread of generalized, and below encephalogram, well, it is shown as normal because alpha rhythm is located in rare part, but excessive spread of alpha rhythm with correct gradient. And these curves are unusual for the doctor. This is coherent analysis, which helps us to assess simultaneous process. And these two peaks at the frequency of basic rhythms, which are the same everywhere, is done for that very patient with expressed anxious effect between the hemispheres and inside the hemispheres. During the recent time, we got a new way of analysis which is used and developed by a psychiatrist. This is dispersion analysis, because considering native encephalogram, normally you cannot see alpha rhythm, and spectral analysis will not be helpful here, but dispersion analysis will make it possible for us to see that actually it is present in all the sections, and it's important not that it is present or that it's not present, but the degree of combination of alpha rhythm with the rear and front departments. At the end, this is the norm of dispersion allocation, top forehead and down a rear part. And two patients with excessively consolidated alpha rhythm at anxious effect, anxiety effect. Neurotic pattern of tensed type. Lots of people who believe that they're healthy, and neurologists believe they're healthy, but they have peculiarity. It's not necessarily that they're truly ill. They have condition of internal load. Externally, they're a little bit slow, and for them, minimal discomfort, a bad word or something will result in effective reaction. For them, it is typical to have this kind of encephalogram of low voltage dysarrhythmia of fast type. Fast because there is a huge quantity of spread beta waves. Then alternating type. This small piece of encephalogram is hard to explain the situation. Alpha rhythm is here, then it goes down, but there are other methods. Comparison of the record or method of Berg-Fury analysis, that is research of dynamic spectrum, and we see that at some point there is spontaneous turning down of alpha rhythm. And if we remember the scheme when I said how activation and disactivation is arranged, we see that synchronizing processes prevail or desynchronizing processes prevail. This is also neurotic pattern. Well, I don't think that we have lots of neurophysiologists at native encephalogramma. It's hard to see that there are different algorithms. There is well-spread algorithm, but at the spectrum, especially the upper graph, there are two of them. One is for the rare part of the head, faster component and slow component, which are related. Well, I used it to localize the method of three-dimension localization. Mainly, this is well, all people with vegetative disorders, with lots of other disorders, can have not one but two or even three rhythms. So now there is a term of heterogeneity of alpha rhythm. By the way, heterogeneity of alpha rhythm is very typical for schizophrenia, but we could not see that, and at present he happened to see that in a simple method which seemed to us that we only needed for diagnosis of epilepsy. And here, heterogeneity of alpha rhythm is shown through the methods of 3D localization. Look at the low picture, and this is at the back hemisphere, and the other one at the basis of left of the left part. We have already discussed coherence, and now what is the connection between the forehead and the rear part? The low level, and the norm is at the lower picture. It has very low level of well, 0.5 at maximum units, and at the top we see that in case of anxious affect, at super idea of anxiety, forehead and nape connection has a very high level. Well, know this thing. As to heterogenic nature of alpha rhythm, as according to native encephalogram at the top, you can say that there are a couple of alpha rhythms. At spectral analysis, it happens that at the upper area we have totally independent components, which is not depending on nape alpha rhythms. And normally, as a rule, everyone who has such anomaly alpha rhythm have changes in their behavior. And the lower part, well, seemingly it is good encephalogram, but we'll see where the alpha rhythm is. At the nape part, I don't have the pointer. At the nape part, it is almost not present alpha rhythm in the forehead part. The girl I have watched for 16 years with expressed psychical disorders. And the next slide, starting with the literature data from the books. There is a wonderful book in Russia. Not many people know that in Russia. It was published in Donetsk. Encephalography in a child's age by Yevtushenko, and he mentions that expressed sensomotor rhythm in the center of high alpha-shaped oscillations is an index of neurotization, and actually if it's higher than the nape, we can consider it as one of the options of neurotic pattern. Quite frequently seen encephalogram, which people avoid to describe as it is. Or if they, epilepsy specialists see it, they described high-frequency oscillations in forehead parts, but it's not related to epilepsy at all. This is synchronized beta rhythm of high amplitude going from a medial-basal surface of the forehead parts, and this is one of the indices of neurotic pattern of AG. So we have already seen this one. Well, quite a fast option. It's too much time. Well, yes, then, they're pressing me to be in a hurry. So the accelerated algorithm, if it is not created at the spectrum for the narrow range, then that is one of the options of neurotic pattern EEG. And I would like to emphasize, I have to be quick because I am running out of time, that structural functional organization is a very important thing. And here is a typical, this is coincidence or miscoincidence frequency of algorithm in forward part and in rear parts. So if algorithm is information transfer, then forward and nape work at different frequencies. Two radio frequencies work separately. That is why the systems of functional organization are the basis of this. So the picture in the middle is the option, which is an index of dispersion when there is a shift of frequency of algorithm in forward part, and this is typical of syndrome of attention deficit scarce. This is typical of somatophoric disorders, and this is more typical of schizophrenia. And below you have the normal picture. Okay, then I will have to finish here. If there are neurophysiologists here, please take picture of this slide. These are regulations for alpha rhythms frequency for different age groups. This is from a different report. However, we are often asked about it. That is why I wanted to show this table to you. And the last but not the least, there is always a question about how we should describe encephalogram. You should not break anything. You should describe it according to old tradition. But additions in green read about awakening level, dissociations of awakening level, whether there is or there is no neurotic pattern, and in blue whether there is or no hyperfrontal indices. Thank you for your attention. Thank you very much, Elif Borisovich. As usual, you have provided very important information because you are dealing with encephalogram with children, and children are our future, and lots of changes in psycho-emotional status is observed now. Just a moment. If anybody is interested, all that is described in 7 books. If you want, you can find me. Well, you can address directly, and I can provide also information. I would like to introduce the next speaker, who will make a report about. We have Dmitry Vladimirovich right now, one by one. Drozdov Dmitry Vladimirovich, system of electrical cardiogram, electrocardiology, senior scientific employee, laboratory of business solution based on AI. Please, Dmitry Vladimirovich, you have the floor. Victor Pavlovna, thank you very much. Actually, I'm very pleased to be with so many people on Saturday. And now we are trying to speak about artificial intelligence, and not only. And we are speaking about the fact that we have been working with digital electrical cardiogram for many years. We haven't noticed that, but there is colossal qualitative and quantitative gap which was applied to EEG, and now I remember such a curve. This is Gartner hype cycle. This is this innovation cycle, and I will get back to this picture a little bit later, but I'm pressed for time. I'm not going to comment upon that.
At the end of the 60s, the first commercial system with automated analysis appeared. Approximately 60 years of the whole history. And in the 80s, we started to accumulate experience and analysis. And then we received a new approach. This was microprocessor revolution, and now almost every EEG has ECG has inbuilt function of this is ECG, and not only it goes together with some software. I want to think a little bit more about this slide and this picture. I would like to remind you this publication of 1977. So this is a very ugly structure. On the right-hand side could be used for and to have norm, classify the conditions as norm, requires prompt attention of the doctor and requires the doctor to assess dynamics. So again, I will remind you, so this is here in 1977, or and just a two situation basically. It's either a prompt reaction or requires dynamics. He's Lev Chirekin. This is a doctor working in St. Petersburg, and he graduated from military academy. And if you have a chance, then it would be nice to just to inquire into this matter. And his thesis and his paperwork, I wanted to bring it with me, but I was not allowed to take picture of that when I was at one of the centers where they store this info. And I just want to say that it's really interesting to read more about this personality. But let's come back to this slide again. Right now we see that the life cycle of innovations at the same time, I mean, as applied to the automated ECG analysis, we have different technologies, and they are located at different stages of this life cycle. All people have heard about neural networks, artificial intelligence, different machine learning, and many other technologies that have already become buzzwords and full of this hype. And hype inevitably leads to the creation of something fake. IT technologies we're working with, and so that can be found within this plateau of productivity. This is a routine analysis of ECG, predetermined logic that was developed and have been developed for almost 50 years. Some comments will be provided a little bit later. Right now we have widespread propagation of something that is called marketing race. Marketing say that my algorithm can make 120 conclusions, others say 121, and our practical experience tells us that the results of photo analysis are not always very accurate, and just like was 30 years ago, and now almost every this automated conclusion can be really classified and based on the smiles on your faces. You also know that. So as a result, we have a catastrophic gap between practice and this theoretical part. I like to talk about standards. That is why I first start with absence of any standards, and rules of measurement are not applied either. I swear it. I could talk about this for an hour. Use of different criteria for diagnosis by different manufacturer, and of course subjective difficulties related to the assessment of the algorithm and also interpretation of ECG. From this perspective, the work that is now being done, I just want to share some secret with you, that is now being pioneered in Moscow, can lead us to get not just practical but also scientific results. I would like to remind you, automated analysis of ECG, this is always a stage process. So accordingly, when you have a stage process, it also can accumulate mistakes. That is inevitable, unfortunately. Accordingly, let's look at automated analysis. If it is linked to automated things, heartbeats, axis, and major interval, there are not so many mistakes, but we need clinical data, and as a result we know that it needs to be injected in the algorithm, and we could have here either time or inaccuracy of data, and in this case inevitably we can predict some mistakes. Here is the question that is still being discussed by special literature, and medical experts have their own own opinion, engineers their own, and so they haven't managed to reach any consensus. Should it done based on a representative or an average set of ACG? If you wanted to change something on your own, then you work with a representative complex, and as for machine, they usually work with average figures. As a result, this average complex might fail to be similar to something that you will pick. So I criticize this analysis, and now I would like to add something more. There are at least 4 categories where automated analysis become the basis of analysis. This is Holter monitoring, where you can organize 100,000 complex. Probably 40 years ago, it was feasible. It could be done visually with some magnetic recorders, some analog approach. But I think that there are no specialists left who can do that. So the second, this is monitoring of ECG with the first system of alarms with the key words is a prompt that allows more or less calmly work in intensive care units where a patient is being monitored. And this is a subject of external defibrillator. And sorry for my slant, but metal, some structure, and does not, algorithm allow to apply some dangerous, hazardous electric impulse where it is not suggested. So it has multi-level and multi-time system of protections. And number 4, this is a switch from to our next presentation. This is implantable cardio stimulators, cardioverter defibrillators. But I should say that it's not almost possible at the modern level to work with them. But let's have a little bit of hype. Big data in ICG. Any modern archive of ICG has all the features of big data. We see that, for example, the so-called NV race. Things like velocity, variety, veracity, and so on. But what about the big archive? What it is all about? And in every case, this big archive has its own specific features. As applied in our country, we have the so-called unified cardiologist of Tatarstan. It's not very popular outside Tatarstan. That is why I'm showing you this slide. Right now, in the system, we have 237 ACG special systems for daily registration of pressure and holders, 75 and 160 correspondingly. As for users, this is amounts to the number of 13,000, almost all the cardiologists of Tatarstan, and 3 million people attached to this program. I would say that probably just it covers the whole population apart from some remote corners. The result is incredible. That is a big archive and based on the experience, we can understand that the expected results and real results of the system based on the category of the users must vary, and based on that we might have different level of efficiency. It will depend on someone who manages it, and as for example, a specialist and doctor, they might manifest different results. A few words about organization, control function of tele-ACG systems and auto-analysis. They can be there. The system allows to control a lot of various things, control not from the point of view of different disruption of violations, but just as a matter of assistance for the doctor, because the doctor in the current routine might fail to finalize something, and if the system supports him a little bit, so then it will be just for the best for everyone. And even though that here we have control functions, but this is control from the point of view of the process management, but not when you come over and say something. Artificial intelligence. This is something that we are trying to achieve. We know that accumulation of electrocardiographic and other data allows us to use different technologies of artificial intelligence. These are expert systems, systems to support decision-making process. It can also be seen. It is presented in the exhibition, and it will be also important for our technicians. There are quite advantages. The virtual systems for technical support. The point that the bigger the system, the more difficult it is to support it technically. And if possible, part of the technical support can be put on the machine. That would be really nice. So you just only need to work with the materials, to structure the right way, and to have a proper diagnostic process. And here we have the end of the loop. The system gets better, and there we manage to work at it in a more comfortable way. I think that, yes, I can. Before I say hello, say thank you for your attention, Ekaterina Andreevna, if you don't mind, you see, I'll have 20 minutes for you. I wanted to quickly read a part of the quotation from a nice book that was interpreted in Russian back in '74. It can still be found at the Leningrad library. A computer machine have a certain disadvantage. It can be accurate, it can be more productive, and also can be help optimize cost. But yes, it can interpret electrocardiogram, but cannot assess the overall state of the patient. I think that is still relevant. Thank you very much. Thank you very much, Dmitry Vladimirovich. That was a really interesting presentations, and it's really great that digitalization and healthcare, that's exactly what our organizations are striving to achieve. And now I'd like to give the floor to Ekaterina Vladimirovna, because she also has a very interesting presentations. She will be talking about cardiostimulator. Ekaterina Vladimirovna, she is a candidate of medical sciences and doctor of functional diagnosis at the State Clinic number 4 at Department of Moscow, and also specialist for implantable arrhythmic system cardiologist. Ekaterina, please, over to you. Yes, I will try to meet your expectations. I was given 20 minutes and we will go quickly through our slides, because I actually have a lot to share with you, even though that the subject is side narrow, but it's can be open up and change when you discuss it. We understand how to work with ECG, you know how to work with cardiostimulator. When we talk about patients with any implantable anti-arrhythmic devices, we have different factors to consider. So we need to also consider the rhythm of the heart itself, as well as the condition of the stimulating function of this device. So we need to assess specific arrhythmia, different conditions, and assess additional parameters, functions, and based on these results, we also need to change the signals that sometimes can be really difficult for the doctor during the analysis of any electrocardiographic study. So as for the systems that can we offer at this stage, we have 4 main types of it. So it's the first one is so-called permanent cardiostimulator that have their own properties, and the devices that are aimed to treat and to log sudden heart arrest, and also to help to treat chronic heart insufficiency, and usually it's the result risk of sudden death because of the heart arrest, because of the problem. And not long ago we got another group that was called heart contraction modulation. If the first 2 groups they are a little bit intersect. Why? Because they all have can use as anti-radiac function performing devices, work with different kind of frequencies, low frequencies and high frequencies, but modulation of heart contractions. This is quite a narrow category of devices that can be applied right now for treating chronic heart insufficiency with decreased refraction. And this group of patients, they don't have this kind of, but they have special ventricle stimulation in order to have the heart to preserve its activity. Depending on the type of device that we have, we might assess not only the main values of the organ devices, but parameters, but also assess additional opportunities and assess the presence of arrhythmia in ventricles and substituting rhythm. The devices that have it's not just implantable defibrillators, but also certain system with a special system of defibrillator. We can assess the algorithm of stimulation and cardioinversion support, and also stability of biventricular stimulation with implantable systems. Don't forget that analysis of ACG, of any duration and any names depends not only on who is actually in front of you, but also on the algorithm and functions parameters were programmed for the patients before he or she came to you. Right now, modern cardiostimulation is referred to as physiological, but this term is not just about the use of these physiological regimes, but also we should say that modern devices allow to create algorithms that could support both slow, averaging, and high heartbeats. And they should not initiate any dangerous sedation and tachyarrhythmia that also really reacted to the atrium behavior and ventricles and not to the noise of some undesired sound. Modern devices must be really economical from the point of view of your costs, and they also should be really comfortable so that we can accompany this patient in the post-operational periods, ensuring technical and clinical support from that. All the patients, regardless of what is implanted, they require on a monitoring and not just you should take drugs for appearance sakes, but also it should be properly monitored. Diabetes and many others can lead to inferior clinical situations. This is one of the basic studies that allow our patients to live long and to choose the right therapy for a patient. And of course, the last, which is always mentioned here, this is planned or scheduled checks for a follow-up. And as for those with installed ventricle cardiofibrillator, they also require some physiological functioning of the prototype, and they should comply with a number of points. As for the three-chamber devices, we must do something for them to have a biventricle efficient stimulation. It's not what can see on ECG, but what works as a stimulus. Both right and left ventricles, they can provide, it should provide for active stimulation situation where we have decompensation. We, as a specialist,
We should have offered to these patients to change the length of interval and interventricular delays, so technically to help this patient to correct this problem. But we still should select adequate doses of all the medicines which are required to treat this problem, and medical therapy correction of main diseases of the patients are at the first positions, and we can only help adequate actions of cardiologists with these patients. And as to the patients having cardio defibrillator or function of defibrillators in their heart system, modern tactics presupposes minimization of cardioversion support and movement to stimulation as a more painless or less painful but efficient way of treatment with. That is why, yes, an attempt to decrease the number of non-motivated shocks consists not only in proper programming of the system stimulation using modern antiarrhythmic devices, but also in combined care of such patients. And that presupposes a medical therapy and also invasive research and radio frequency ablation of heart rhythm distortion as often a source of non-motivated coordination shocks with this category of patients. That is why, when we consider a cardiogram, the doctor should answer 4 questions: whether this device works properly, and whether the stimulator of any kind participates in formation of lower or upper frequency of stimulation rhythm, whether this device can identify the device implanted into the heart of the patient, the operation of a heart and how it reacts to the perceived signal. The noises which do not actually exist in the heart chamber should not be identified by this device. And we should assess the distance between neighboring stimulus, between the stimulus and any sequence, and know what kind of algorithm and what kind of parameters we relate the researched intervals. And the last in this ring, and for you it is actually at the first part, is to assess whether the stimulus is efficient, whether the stimulus creates myocard activity, and if this results in moving of several chambers of heart, in which sequence, one by one, or in concept of general operation of this device. So you have to know all these points, how this operates. But most often when we speak about analysis of cardiograms, we speak about analysis of stimulation modes. That is quite a routine statement, and we use this from 2001, and I show you this slide not to remind of how that looks like, but just to show that physiological regimes of stimulations are these regimes identified. Well, I'm sorry. Please bring back the slide. So, I would like to attract your attention to the right part of the screen. I have singled out asynchronous stimulation regimes that are called non-physiological ones. And you should understand that in every specific case, it will be individual. And patients who doesn't have own heart rhythms, these regimes can have functional physiological regime of stimulation for a specific patient. If a patient has own active heart rhythm, then these regimes of synchronous stimulation can sound as a physiological competing with own heart rhythm. And this slide shows you that not only single chamber but a double chamber regime of stimulations can look like isolated stimulation. Looks like you see that I show you this stimulation, but at cardiogram it looks like pseudo stimulation. And you should actually know how this works, everything from the basic algorithms assessing the stimulation mode. But regardless of this, you should should know additional condition of percepting function of the device and arrhythmic presence and the presence of efficiency of stimulation, and assess or have care in assessment of the ST segment. Stimulation in percepting functions are main functions in operation of cardiostimulation devices, and it's out of the question should be known first and foremost. Why? Here we move on to terminology. Cardiostimulation should perceive information exclusively from the heart chamber, which is asked according to the programmed regime of stimulation, and then shouldn't perceive any parasite signals only for this event. Stimulating function of heart presupposes that cardiostimulator should use stimulus and excite myocardium normally using classical regime of stimulations at location of stimulus outside refractory myocardium stimulated chamber of heart, and this will depend on a programmed regime of stimulations. Fracture of myocardium is a very important indicator which we should get oriented by. Why? Because we have further development of our communication. Efficient stimulus will be shown as excitement of myocardium, as is shown in this scheme, and when we have it outside the refraction period of heart chamber. If these are located outside it, I will provide you this is located far from artificial complex, but is not result in excitement. Here, the stimulus is far from P wave and does not result in excitement of myocardium, and this will be inefficient stimulus and distortion of stimulating function of the device. Here we see different palette. I have put question marks because cardiostimulator doesn't know at which part and what exactly it sees. We do not know. We could see if we had electrophonogram and we would know how to correctly assess that, but we cannot judge upon that. And the main thing is that in red arrows you can see two stimulus which are located inside refractory part and the chamber of heart, and the second as well. And P wave is located in front of the stimulus, but the refraction still continues, and the stimulus applied behind P happens to be inefficient. However, it's not called inefficient. It is unimplemented because it cannot realize its amplitude, longevity, so functional and physical qualities of the stimulus to cause excitement of myocardium in a heart chamber. Another situation, this condition has its own names when we speak about triggered stimulation, and that happens and is used mostly in CRT systems and in modulation devices for heart rhythm and some cardiostimulators as part of component of the algorithm of stimulation. That is why pay attention to stimulus location. However, don't forget that this direction is not analyzed, and until now we see statements and for that there are different amplitudes, different directed stimulus. This is something terrible. Save patience, but it does not prove anything. Different amplitude, different prolongation depends on polarity of what we used. But if we saw high stimulus and we said that this is a molecular configuration and a small bipolar configuration, depending on the location, and as to cathode and electrical currency between them. Well, at reception and usage of special algorithms which are meant to test amplitude and stimulus and save electrical energy for cardiostimulation, and the small stimulus can also be monopolar. Then when you describe a cardiogram, please be careful. Don't speak about polarity of the stimulus. If you see some small stimulus normally causes doubts. Well, some cardiograms I will show you one by one. What do you say this cardiogram? Definitely you see some stimulus that overlap, and as to pseudo-emerging. And what do you see for the heart channel? Do you see P, and what are they caused by? See the red part of the screen where you see parameters of filtration of the signal. Here is the stimulus that I saw, and I show you with the stimulus with these notions of filters. And if we change parameters, then we'll have a higher quantity of stimulus in this cardiogram. And if we change another indication of filtration, we'll see that almost all of the events at this cardiogram are established with artificial complexes. All the stimulus are efficient, but one. The one that looks like extrasystola, but actually it's not extrasystola, but they conduct it with the help of p-synchronized stimulation, double chamber stimulation mode, and everything started with totally sterile cardiogram where we never saw the stimulus. And here I would like to attract your attention. Please train nurses when they communicate with the patients at this stage of removing clothes. Not ask only name, age, and where do they live, and whether they have a cardiostimulator or not. This will make it possible for a nurse to use this filter if it is not amortized device and a computer system, just to provide assistance to you to have the result that doesn't need to be fantasized about. Another capability of modern computer systems. Have a look. What do we see here? The stimulus is seen only if we apply special channel of registration of inner heart signals at the surface cardiogram, which only two producers have, DMS and Ostrocard. And as we see the stimulus and we can speak about the stimulation of auricle and with the auricle connectivity up to 4 milliseconds, but we cannot say what kind of stimulation regime is there, which parameters are programmed, because this picture they can be shown at a couple of options of work of our devices, and we need the knowledge that you had to interpret with this data in your analysis. Another cardiogram. What do you see here? Extrasystolia, and I tell you this, but if we change filters, you will see one channel that P waves are located in isolated auricle stimulus, efficient auricle stimulus, and not only sinus rhythms, and two actual auricle systols, and please use different methods to improve visualizations. Don't forget old method, which makes it possible to improve visualizations of low amplitude events as increase of calibration for the signal. You see up a diagram, you see some pause, and you know what it is about, but if you increase the amplitude of calibration signal, you will see that this is the pause made by P waves, which participate in a restart of intervals of stimulation, thus according to the algorithm and regime of stimulation that was programmed for this patient during the last visit. And again, don't forget about noises and different defects which can be at any registered techniques. Please ask our patients about parameters of device operation for the nearest follow-up performance programmation of stimulation system by our colleagues. Why? Because if they have such a prints of 1 year old or 1 month ago, I looked at that 2 days ago, and I could have changed these or that parameters, which inevitably would find reflection at the surface cardiogram. And depending on basic patterns, we should not forget that all the devices worked based on timings, and main mass of the device which are sold at the territory of the Russian Federation have ventricle timing and only one auricle timing, and you can read in detail about it in National Recommendation on Functional Diagnosis, which was published this year. I saw that at the stand, and differences between these timings are very well noticed when in the heart of the patient there is auricle ectopy, and in this case, in this situation, Well, I selected similar type of auricle ectopy, which happens quite often. You see totally different pictures for heart rhythm. And if auricle ectopy is not there, then another auricle timing will be almost identical with visualization of frequency rhythm of heart. But in this case, there can be a longer distance between RR due to the length of ventricular conductivity. Well, at this diagram, you see not only the stimulation regimes, but different patterns related to programmed algorithm of stimulations, and that is why many cardiograms can look like distortion of stimulations, which, as you seem to be a disorder, but they're not true disorders, and it is reflected as these unclear cardiograms. And one of my favorite slides, when at one small cardiogram you see operation of several algorithms, namely the auricle activity and synchronizing ventricle stimulation, reaching maximum frequency and stimulation of auricle events, and then algorithm, and then intervals, and we didn't program this, and it works as it is. And then we have ventricle stimulation, which actually controls the heart rhythm during physical load. And at the same moment, within these 10 seconds, you have an opportunity to assess and to see how several algorithms of stimulation work. Ventricle stimulations we try to minimize and give advantage to auricle stimulation when we speak about regular cardio stimulation. And when we speak about CRT systems, we have to strive to reach 99% of the ventricular efficient of stimulations in order to reach efficient functional physiological stimulation. But I would like to attract your attention. This cardiogram of a patient CRT system, which has a well-expressed ventricle ectopy and low channel registration of stimulus of this cardiogram shows you the presence of stimulus, but you see that all the systems are totally different. All of them are wide, and all of them are while analyzing this cardiogram of Holter monitor that you can see here, you should visually identify what is responsible for what, and you should have the cardiograms that actually we should have provided to you with the help of a patient, where you would see patterns of isolated right ventricle stimulation or left ventricle stimulation, and the result for the patient. And then you will be able to assess morphology of during your researches with morphology of complexes during testing research. And have a look. The most similar operations which I identified as guaranteeing and left ventricle stimulation, and at this part we have timely losses for left ventricle stimulation. If I single out with the color, this looks better. However, I identified with the color when analyzed Holter monitor, and there we need knowledge, and I would like to attract your attention to the fact that these patients with implanted CRT systems should have in 12 connections, not in 1, not in 3, but in 12 connections. Why? Because it's of utmost importance to assess this biventricular stimulation. Of course, arrhythmia is also important. Biventricular stimulation and its percent is very important. And in conclusion, I would like to provide you a clinical example. Well, this kind of excursus. Have a look. What do you see here? What do you see here? Well, I will make it brighter. What can you see? Do you see P waves? Yes, you do. And what is this? This cardiogram can be present by any person sitting here and not having cardio stimulator. Why? Just pay attention that we have a parameter of registration of the signal, and pay attention that this low amplitude registration of signals is related to the fact that this cardiogram was taken at a calibration which is 2 times less. So why? Nobody will tell you. Somebody gave me this cardiogram. So it's not only that you cannot see stimulus, you can hardly see P waves. So remake this cardiogram and pay attention while analyzing this cardiogram. And once again, don't forget about documentation of this patient.
if you know that a patient has an implanted system, this is the one that belongs to this patient. What we can see here, normal parameters of calibration of ECG signal, sinus type, rhythm between 60-62 beats per minute, and also you can see a pause up to 1.5 seconds that is regarded as normal. And if something goes wrong, when you think that machine goes out of order, go wherever you want, where this cardio stimulation tool was installed. But if you look at this cardiogram, what we'll see? So this what was seen by the doctors, and we want to see what was here. But if we look at this, we'll see one pre-atrium persistal that will be added to our final conclusion for the description, and then we'll need to know what kind of stimulation is programmed for that. Here we have an isolated atrium stimulation with so extracecal, so that we can have another part of stimulation. We have a pause after 10 seconds.
Oracle.
For a cardiostimulator working in isolated is a problem. If you took a document of this patient, or also from the stationar, or asked for patient's history documents, that we can see and this one came over with quite unspecified complaints, and what we can see here, isolated ventricular stimulation. We can see auricular atrium stimulation, and the others are formed based on the frequency that has been programmed on the previous. And if you look at the previous cardiogram, you will see that it's not possible, but it is still there. And the only electrographic events that you can use here is just for the control to do. What is so best about this isolated ventricular stimulation? Because here we can have retrograde activation of the atrium and different manifestation of different symptoms, but this state is not something bad, or it tells us about an improper violation of the functioning, but no, you just can need to add an electrode to find a remedy to that. But this depends not just only this picture, but it could be just different patterns that remind us V3 community. We need here some creativity and relevant approach. As for ECG system, we cannot afford, because 65% with ventricular stimulation, even without permanent stimulation, could manifest some pseudo infarction state. If we also have here pre-atrial electrodes, so it is only applied to the patients with permanent infarction, and all the other groups of patients require 2-chamber or 3-chamber stimulator. And the conclusion that is given here, that is needed for describing big scope of ECG, you can read it at the slide, or a national recommendation out of 14 years, but to minimize difficulties and mistakes during ECG analysis of any longevity. Please take documentation of our patients and models and producers of these devices. If you know how it works, it's fine. If you don't, ask how this algorithm works, as well as all those mechanisms for the formation. Be attentive and use a descriptive style where you describe something. Why? Because even me personally, might not know how different systems works. So descriptive style, something you can see, you definitely need to describe it. If you want to get some data regarding arrhythmia or some arrhythmic events and training angiogenesis, you can send documents to my address. If you need help and analysis, with analysis, you can also do this. And to summarize, I would like to thank you that there are so many people, even though that is really late. You can see the audience room is almost full. Do you have any cardiograms so I can take a look at them? Then, upon completion of this section, we will get here and we'll analyze them, but a little bit later. If you want to, you can erase and also observe it. Thank you very much. Thank you very much. So I couldn't just stop you because I saw that there is a real problem when in a hospital we get information with cardiostimulator and we cannot always interpret all those cardiograms. It sometimes leads to hysteria because doctors cannot perform functional diagnosis and describe it in the intelligent way. And we all saw that we have very diverse subjects. We have a functional diagnosis in any domain, in any clinical specialty. It is used in a very intensely. That is why we must always stay intelligent, and we must help our clinicians to properly diagnose. Thank you very much. Congratulate you. Don't forget to go for a service at the church. Stay happy. Wish you all the best.